Okay, so thanks everyone for joining. We had an overwhelming response to this webinar. It is the second webinar focused for OTs and by OTs. My name is Fiona Breitenbach. I'll be hosting this session and I'm joined by two speakers who I'll introduce shortly. We felt that it would be beneficial to host a webinar on sexual functioning for our spinal cord injury clients. Oh, sorry, I'm just going to mute this person. Okay. So yeah, we thought it would be beneficial. It's a much needed area and often a very sensitive area that's often ignored. But I hope by the end of the session, you'll be empowered with the importance OTs play in this critical area of our client's life. And whether you're new or experienced in spinal rehab, and whether you come from a high or low income country, we trust that it's going to assist you in your clinical practice. Just a bit about myself. I'm a lecturer at the University of the Witwatersrand in Johannesburg, South Africa. I'm currently working as a lecturer and course coordinator for the undergraduate and postgraduate adult neurology modules in occupational therapy. Prior to academia, I worked in an acute central level hospital in a trauma unit where I mostly treated head injuries and traumatic spinal cord injuries. Before I introduce our two awesome speakers, I just wanted to also introduce our moderator, who will be moderating the Q&A chat. So Nikki is currently works as the coordinator for spinal OT services in a statewide spinal unit in Perth, Western Australia. She's got extensive experience in inpatient, outpatient, and outreach services across Australia. So thank you, Nikki, for also joining and moderating this session. Just looking at the hour ahead, our speakers will be presenting for the next hour, and then we'll have half an hour for Q&A, which is quite a substantial amount of time, but I think it is a topic that requires a lot of discussion and a lot of interest. So just to introduce our two speakers for today, Nica, if you can just pull up that slide. So Iva, you're going to have to help me with your surname.
It's Hradilova.
Okay, that's but Iva is from the Czech Republic, and she graduated with her bachelor's in OT in 2009 from the University of West Bohemia in the Faculty of Health Sciences. And in 2023, she obtained her master's degree for adults. From 2009 to 2012, she worked at the University Hospital in Pilsen. Sorry if I'm mispronouncing these things. And she's also been working as from 2009 to 2019 as a lecturer at West Bohemian University. And from 2012 till currently, she is now at Centrum Propale. For social rehabilitation center for people with spinal cord injuries. She was in the position head, and she has a keen interest in sexuality and relationships. She's a co-author of a book called Yes We Can, Kama Sutra for Wheelchair Users, which you'll hear a little bit more about throughout the presentation. And then Nica Pietersen, she's an OT based in South Africa. She completed her undergraduate degree a few years ago. I can't remember how many years ago. And she's currently completing her MSc. She's about to graduate or submit for graduation. And she's experienced in a spinal cord injury unit in public healthcare facilities as well as private rehab facilities, and is currently working in a home-based setting. She's also very passionate about bringing a greater focus to sexual functioning in low-resourced areas. So welcome to both our speakers. Thank you so much for all your effort in putting in this time for this webinar. And yeah, I'm going to hand over to you.
Sorry, I just couldn't grab my unmute button. All right, can everyone hear me? Okay, so thank you for Fiona for the introduction. So these are the areas that we'll be covering in our presentation today. Starting first with the social and emotional aspects of sexual functioning, and then moving on to positioning, aids, and adaptions. All righty, so let's start by looking at therapist-client communication. As therapists, we need to remember that you set the tone for how the conversation occurs. And it's probably your client's first time ever really having these discussions around their abilities, around sex. And the way the therapist approaches it kind of dictates how the client will view this topic for the rest of their lives. So you really do play a vital role. It's a very personal topic. So there should be a good mix between presenting factual information and drawing on experience. So this can either be personal experience or from your other patients if you don't feel comfortable sharing that information. But just remember that if you don't feel comfortable sharing information, you can't necessarily expect your clients to be comfortable. It also needs to be an emotional discussion because it is an emotional topic. And it's important to not make promises, but to still inspire hope. Before initiating these conversations, we need to start getting ourselves comfortable with using the correct terminology. Penis, vagina, sex, orgasm. These are words that need to be part of your everyday vocabulary. So here's an example of kind of a good way to start this conversation. The ability to form or maintain an erection can be affected after spinal cord injury. Most of my clients have experienced one and or the other, and they were also worried about this at first. And it can be a big stress for most people. Is it something that you've thought about at all, or is it something that worries you? As much as I cannot tell you what it'll be like, I can explain to you what areas can be affected, and we can go from there. Just know that no matter what your level of ability, you can still enjoy a very satisfying sex life. Okay, so that's the type of way that you can start introducing this topic. Give information, ask questions, and just bring about the topic for the first time. So before you even start having these discussions, we need to dismantle some of our own assumptions. We all have some level of internal prejudice, and we need to start by working through that within ourselves. So firstly, sex is as important to women as it is to men. So please do not forget to broach this topic with your female clients, not just your male clients. Secondly, reproduction is as important to men as it is to women. Don't forget to discuss this aspect with your male clients. And just because some women are more modestly dressed according to either their religion or their culture, it doesn't mean that they're not as sexually active than those who show more skin. So don't be put off by religion and culture. Not all sex includes a male and female. The LGBTQI+ members also experience spinal cord injury. And we need to become more comfortable discussing these types of topics. So not just a penis, vagina sexual intercourse, but also looking at anal intercourse, as well as oral stimulation and digital stimulation. Sex is not solely for the purpose of reproduction. So ensure you're not passing judgments on clients who don't have a single sexual partner. And lastly, sex is also not solely about feeling pleasure, but also about providing pleasure. And in my experience, my clients are a lot more focused on if they can provide pleasure, not just receive it. All righty, so looking at overcoming a language barrier or a cultural barrier. I know in my country, language barriers, cultural barriers are very common, and I'm sure they are in various other countries. So in overcoming a language or cultural barrier, we need to remember that us as OTs, we are skilled assessors, and we can draw on this skill. Continuous assessment in the form of interview is imperative, because the only way to know is to ask. In my research, OTs use multiple ways of navigating language barriers. It includes informal interpretation, formal interpretation, Google Translate, non-verbal demonstration, pictures, translation cards, all to communicate various aspects of therapy. And all of these can also be implemented in discussing sexual functioning. So draw on those skills that you have in order to provide the information that you need to your clients. Bringing this topic up on initial assessment is vital. I know it's something that we want to build a good rapport with our clients first and bring it up later, but initial assessment is vital as the client will understand that you are the person who will be addressing this topic going forward. And that can kickstart the thought process around this topic. For a lot of clients, it's the first time they've ever thought about it when you mention it. They've got so many other things to think about. So make sure that they know that you are the person who'll be working through this aspect with them, so that if they have any questions, they know who to come to. Once you've broadened the subject or broached the subject for the first time, let the dust settle a little bit, give your clients a chance to think, and then gradually gather more information about their previous sexual activity, their sexual health, their sexual preferences. This also gives your client time to think a little bit more about questions that they might have or information that they might want to share with you. And remember, just like any ADL, we assess pre-morbid function, current function, and then we predict outcomes with the patient. So we cannot sit in our own little, offices and start to think of outcomes that we want around sexual functioning without including the clients in these topics of conversation. Alrighty, so looking at client-partner communication and how we can facilitate this. Before the client communicates with their partner, they need to be able to communicate with themselves. So try and in your therapy sessions, practice identifying and naming areas which experience changes in sensation. And this can be an isolated treatment session, getting your clients used to saying things like, oh, my neck is very sensitive. Focus on that area. It feels really good to me. Or being able to communicate to their partner that, my nipples are too sensitive and it sometimes hurts when you touch them too softly. But if you massage them, then that starts to feel good. So actually being able to verbalize these topics is a treatment session in itself. Remember, stigma and stereotypes exist around sexual functioning, following an SCI specifically. And it usually stems from a lack of knowledge. So providing that lack of knowledge, firstly to our clients, and then for them to communicate it to their partners, starts to take away that stigma and those stereotypes. Communicating around desired partners, around your abilities, your needs, and wants, it's all necessary for all individuals, but especially following spinal cord injury. And when experiencing difficulties, we need to keep in mind that it's not either partner that is the problem. You're not bringing a problem to the table as an SCI client or someone living with SCI. There is a problem, and that's difficulty engaging. And you can both work together to overcome this problem. And this in itself builds trust and allows for better communication, and then further enhances your sexual experience. So let's look at this interesting take of my partner is also my caregiver. This can happen in many societies, especially when a caregiver cannot be afforded, and often the partner then takes on that role. So when they have also taken the role on as a caregiver, there might be some trouble disconnecting the one role from the other in order to participate in different activities. A special name only used when engaging in sex can be used to identify this role change. So you want to create kind of a border between when one role starts and the other ends. So for example, when your partner is assisting you in catheterization, they can refer to you using your full name, Catherine, and you refer to him as his full name, John. When you want to engage each other in foreplay or in sex, that's when you refer to him as Johnny, and he calls you babe. So just those small little changes in how you communicate with each other really can dictate in which role you're participating in, and can open both you and your partner up to sexual engagement. Additionally, a change in vocal tone can also help separate the roles. For example, if you're talking to your partner when they are catheterizing, you would speak to them in a very formal way, the way that I'm speaking to you now. But when you're wanting to engage in sexual functioning, light contact with your hand and starting to use a bit of a flirty mannerism really can help separate those roles. These are things that most people do anyway. So without even realizing it, I'm not going to talk to my sexual partner this way, even without a spinal cord injury. So these are things that we do as humans and can be capitalized on when having a partner caregiver situation. In saying that, spontaneity does exist. And you might want to use an opportunity during a caregiver situation where you want to engage in sexual functioning, such as if your caregiver is busy washing you in the shower, you could very easily become aroused by that. And with the simple use of a different name, your partner knows, oh, suddenly sexual functioning is on the table. Alrighty, so this is just areas of sexual functioning that are affected by spinal cord. And we won't go into too much detail because we'll readdress this at a later stage as well. So we need to also consider self-acceptance. There's really nice ways of including grooming and makeup routines and shaving routines and getting your clients back to feeling like they're themselves again. And this can often be the first step into approaching sexual functioning. So finding yourself attractive again. So communication, we've spoken about this already. So that's often affected by spinal cord injury. Attraction and flirting, as we said, being sexual also means needing to feel like you're accepted, especially at the beginning. A lot of our clients feel like they're hospitalized, that they're patients, and they start to dehumanize themselves and lack that feeling of attractiveness. And it's our role as OTs to make sure that we give that back to them, or provide a means with which they can find that themselves. Keeping in mind that your clients have lost something in terms of a mobility aspect, and sometimes they can't use their full range of nonverbal skills, such as gestures, or change in posture. And we need to explore other forms of being able to do that. Okay. And lastly, we're not going to go into too much detail. I think there's a lot more to explore in this, but we need to be aware, and our clients need to be aware of sexual violence and how people that do have limited or decreased abilities physically might be more of a target in terms of sexual violence. So we need to, as well as we provide means of engaging in sexual functioning, need to ensure that our patients are empowered to also defend themselves in these situations if needed. All right. So when considering sex, we need to acknowledge that medical changes have occurred. The body itself has changed, and this can have effects on your moving, your sensation, reactions, your pain, emptying of bladders, etc. And so sexual appetites can also change, often as a result of medication and side effects of medication, but it can also be affected by fatigue owing to the amount of effort that has to be put into other activities of daily living. We can also have erectile and ejaculation difficulties and dysfunctions, as well as difficulties with vaginal rehabilitation and lubrication. We might also have the ability to, or lose the ability to have an orgasm. We have various medical complications. I've popped them down there so you can just have a look at those. And autonomic dysreflexia in particular will be discussed in the next slide. And for many of these physical limitations, there are ways to mitigate and to compensate. So we need to educate our clients on these and then at the same time provide possible solutions for them. All right, so autonomic dysreflexia. It's a life-threatening condition, and it's risky for all patients with a spinal cord injury above the level of T6. And it's caused as an inappropriate body reaction where blood pressure rises quite sharply due to an irritation below the lesion site. And therefore, keeping in mind that sex is then a very common cause of autonomic dysreflexia. But it can be prevented with appropriate medication without affecting your sexual activity. So this is if something that your clients are experiencing, as soon as they try to engage in sexual functioning, they experience an autonomic dysreflexia episode, then making sure that they are referred to the appropriate doctor who will be able to provide the appropriate medication is super important. Okay, so where do we start? We start physically with the rehabilitation of the penis itself. So with the male client, we need to make sure that this is one of the first steps in the treatment process. I know, again, it's something that we want to build rapport first. We want to make sure that we're building that connection. And so it often is left to the end of therapy. But studies have shown that getting this or starting this process as soon as possible provides the best results with penis rehabilitation. So up to 75% of men actually struggle with erectile dysfunction following SCI. And the best way to prevent irreversible damage is to start as soon as possible. The primary way of achieving erection during rehab is masturbation. and it's often combined with oral PDE5 inhibitors. So this is a medication that stimulates blood flow into the penis itself. And again, the doctors will be, referred to, and you'll work as a team regarding this. So you might be the facilitator to the actual masturbation, and the doctor will come in with various medications, such as the PDE5 inhibitor. And these PDE5 inhibitors are really easy to insert. You can also use commercially available sex toys, which will be discussed in following slides. So these are really important to have in stock and on hand, because if your client is struggling to masturbate on their own, we need to be able to provide them immediately with the relevant equipment to aid them. Okay, so before we go into the rehab, we ourselves need to understand the various types of erections that are possible. So, and this is important in guiding our patients or our clients in order for them to understand what type of erection they're having. So firstly, we get a psychogenic erection. The cause of this is when you have your sexual or arousing thoughts. So this is the mental game. And this type of erection is not usually possible in complete lesions that are T11 and higher. The ability is required to both form and maintain an erection. So this is really important, you'll see, in the maintenance of an erection. Then we get a reflexogenic erection, and this is in response to a touch stimulation. So it can be triggered by non-arousing stimuli. It's possible in all lesions, so it can just occur. And it really codes for the ability to form an erection. But unfortunately, with this type of erection, it's really difficult to maintain for an appropriate amount of time, and it's usually not sufficient for intercourse. And then lastly, you get a spontaneous erection. This has absolutely no cause. It usually occurs during a sleep cycle, and the duration of this differs. So some people might be able to take advantage of it for sexual intercourse, but there's really no telling how long it will last for. So access to erection management strategies depends on what is available in your country. So we'll review a whole bunch, but just keep in mind that not all of these are available to every country. So oral medications can be considered, and they're a really good option for your low-level paras. There is, however, a lack of evidence on prolonged use and the side effects in people living with SCI long-term. They can, however, be ineffective in your complete higher level paras or your quads, and they can be particularly useful in incomplete lesions as well to increase the duration of your erection. So although incomplete lesions might be able to form, if they're unable to maintain for long enough, this is where an oral medication might be suitable. So we've put some various names here. Your common one, Viagra, but you also get Cialis and Levitra. And about 60 to 80% of paras and quads report that they can maintain an adequate erection for sexual activity on these medications. Then you get the gel. So this is a prostaglandin E1, and it's a gel that's inserted directly into the urethral opening about 20 minutes before intercourse. And what it does is it really expands the blood vessels in the penile tissue and allows blood to flow into that penile tissue, causing an erection. Then you get an injection, the same kind of idea of the prostaglandin E1. It can be injected also directly into the penile tissue. And about 80 to 90% of paraplegic men who turn to this treatment report really successful results. So again, a good idea if there's a lack of sensation to inject directly into the penile tissues. Then you get something called the Vacurect pump. It's a suction mechanism that pumps blood directly into the erectile tissues. So you place it over the penis and then you pump it multiple times and it draws the blood in. And a band is placed at the base of the penis while the penis is still flaccid, which then prevents that blood from going back into the body. And so you can sustain an erection for approximately 30 minutes, which is usually a good enough duration in order to complete sexual intercourse. What's nice about it is there are relatively no risks, very, very few risks recorded with this device. And as you can see, price-wise, for a once-off, it's sitting at about 1,800 Rand. So it's not even, if I'm not mistaken, I'd say that's about $100, which, considering that you can use it for the rest of your life, is quite a good investment to make in terms of a low-cost option. And the nice thing about it is that this item can actually be introduced into foreplay. So we can use this item as a way for your partner to give you an erection, which is quite nice because it's actually involved in the sexual functioning process. We can have a look at implants. However, this option is no longer regarded in literature as very safe and viable, and it's difficult to come across this option still. There's a high risk of infection, high risk of complications happening. And so for that reason, it's no longer highly recommended in literature. And then you can also get something like the neurostimulator. This is more of a high-tech option. It's very expensive and almost completely unavailable, except in your very high socioeconomic areas. And it's functional for being able to empty your urine, your stool, as well as for reflex erections. So it can kind of have a dual purpose. It is, however, an invasive procedure, and the insertion of fibers happens directly into the spinal cord itself. Okay, so then looking at ejaculation. Many spinal cord injured men have trouble ejaculating, but their semen can still be obtained. So there's various reasons why ejaculation can be impaired, but it's usually a concern with men who want to then consider fertility options. So how we extract semen is that it's usually done with a medical vibrator, such as the Verticare by Multicept. You can see that picture 3 below. And what you do is you stimulate the glands of the frenulum, and this induces reflex ejaculation. It's usually done in injuries above the level of T6. It's actually more difficult to do it with your lower level injuries because that reflex isn't as strong. And then what you do is when you've retrieved that ejaculation, that can be used for your IVF. So other treatments can also include electroejaculation as well as prostate massage. But it is found that this way is the easiest and most accessible for most people. Sperm can also be obtained surgically through a procedure called testicular sperm extraction, and this is performed by an IVF specialist. So that would have to be going through the full medical route. And as I said, there's the picture of the Verticare seen below. Alrighty, so let's look at female sexual functioning. When regarding female sexual functioning, the most common question that we usually get is, will I be able to feel? So as with men, they're usually concerned as, will they be able to perform? Women are more concerned about the feeling. External stimulation is usually affected from about S1 and higher. So that is a large population of spinal cord injured clients. But you may be able to feel pressure of the penis at the back of the vaginal wall, even with these lesions. So that sensation may be intact in all lesions. Women do have the potential to achieve orgasm even in complete lesions, as we're lucky in that there's multiple neural pathways that can code for this sensation, such as the somatosensory pathway, and most importantly, the autonomic nervous system. However, it's not a given, and the ability to reach orgasm may require really prolonged stimulation. So besides the physical health components, we need to address the mental and the social aspects, because this prolonged stimulation, the use of various pathways can be very emotionally draining. So Foley and Iverson developed this model of sexual functioning and sexual rehabilitation. So it was originally made for MS clients, but it is actually suitable for SCI clients too. And in this model, sexual functioning and sexual rehab is divided into 3 factors. So firstly, the primary factors. So these are all your factors that are associated with the post-SCI neurological deficit itself. So an example is the reflexogenic arousal that can be tested with touch, pressure, vibration on the vulva and the perineum, as well as stimulating the clitoris, the vaginal opening, the cervix, or the sphincter. So those are your primary factors, the actual sensation changes. Then your secondary factors that affect sexual functioning are your mobility issues, your spasticity, muscle contractures, pain, bowel and bladder control, etc. So these are your secondary factors that aren't specifically as a cause of SCI, but are almost our secondary complications. And then lastly, your tertiary factors, which are your psychogenic and your psychosocial factors. This can include your depressions, your anxieties, substance abuse, low self-esteem, which all can affect your desire to have sex. So looking at female lubrication, they are, as they are in men or male erections, there's different types of lubrications that can occur in females. So number one is your psychogenic lubrication. This is possible in lower level spinal cord injuries that are T11 and lower. So they can have your psychogenic lubrication. And again, this is more your thoughts of arousal and your lubrication in response to being aroused. There is actually a correlation between presence of pinprick and light touch stimulation between the T11 and S2 segments. So if you have those intact, it's likely that you'll be able to have psychogenic lubrication, but it's not always the case. There is just a strong correlation. And then you can have reflexogenic lubrication, and this is possible at all levels. And it's the same as with male erections. That relies on physical touch. So physical touch stimulation can provide lubrication. There is, however, no way of knowing if this lubrication will sustain the duration of intercourse. So you want to make sure that you're using lubricants externally or external lubrication, because the female SCI clients might not be able to feel if they have dried out of lubrication. And this could cause friction, which may result in injury and increased risk of infection. The idea behind this, as soon as you have any infection in the genital region, you're automatically at risk for your UTIs and your kidney infections. So we really want to make sure that we're keeping that area as injury-free and as hygienic as possible. So that's why we want to add in a lubricant at all times. So water-based lubricant is highly, highly recommended during all times of sexual intercourse for all females living with SCI. And a KY gel is a cheap and easily accessible alternative for your higher brands. Alrighty, so then going on to fertility. So for your male clients, semen is then obtained as discussed previously through the previously mentioned methods, and then IVF is completed. There are some cases in incomplete males where natural pregnancy can occur, but if you're having any trouble, then the semen needs to be obtained. In females, we need to keep in mind that menstruation can be disrupted following injury, and chances of falling pregnant until menstruation reoccurs are low but not impossible. So it can happen. Clients need to be aware of that. However, if they are wanting to fall pregnant and their menstruation has not yet returned, they need to consider speaking to a medical professional around that and a person who is specialized in fertility. Pregnancy can also occur through natural means at any level. So it can happen. And women living with SCI are able to carry safely and to full term. The only difference is that the pregnancy will be considered high risk and will require increased monitoring by medical doctors throughout. Now, what's interesting is that there are low pregnancy rates noted in females living with spinal cord injury, much lower than general populations. And this does point to your secondary and tertiary factors that are actually impacting fertility more than your primary factors. Alrighty, I'm going to hand over to Iva at this point.
Thank you, Nica, for a very nice speech. I'm going to be more practice. So now we will talk about everything what is appropriate to prepare for a successful life act. Even in wheelchair, it's still possible to have sex spontaneously, but for successful sex activity, it's good to be prepared. And you can prepare your body, and you can prepare the place where the sexual activity will be, and you can prepare the devices. So for the preparing of your body is emptying a bowel and bladder, and take drugs for the risk of autonomic dysreflexia or for the erectile dysfunction, lubricate for the prevention to micro tears, how Nica said before. And especially for women, it's good to drink some more water before the sexual activity for the prevention of urine infection. And beware of alcohol, although it's reduced psychological inhibitions, but erectile dysfunctions too, effects of drugs on erectile dysfunctions too. So be careful of them. The next one, it's how you prepare the place. Look on the place where the activity will be. It can be on the bed, it can be on couch, on floor or carpet, or in shower, just in case if it's something not there, some small piece of something under your body for to make you some injury, to check the place for the small objects. If you're using the toys and devices, prepare them close to your hands, and you can have some tissue or wet wipes close to you. And it's good to have antibacterial pads for the just in case if something happened. And don't forget the contraceptions. I think that everything is possible. This is only to be prepared to mention the risk for some injuries on something which is not too nice in sexual activity. Okay, another one. Let's talk about the wheelchair Kama Sutra. So the experience and actual course of sexual activity is different than before the spinal cord injury. But it still doesn't be boring. It's possible to find a way, the new way, which can be very nice and pleasure for you. But I think that most important is to have an open mind and look for possibilities. And sometimes it spent very long time. The imagination plays a big role, and there is not universal key. There are many possibilities, and sex can be nice, nice again, but sometimes it spent very long time. So next one, the kind of sexual activity. I think that lots of kinds of sexual activity, but in this way there is a whole spectrum of them. I think that very important is say that penetrations not to be the first priority in sexual activity of people with SCI, especially for the people with higher injury. And it's very important to exploration of the body through various stimuli, and masturbation leads to restart sexual life. How I said before, it can spend some more time, but there is a lot of issue, a lot of things what you can use for to find the new way. And it's necessary to say that all forms are possibility if they are voluntary for all participants. So, but there is no limits for the creativity, but it's only for your pleasure. The next one. So let's play. We can divide the compensation aids into the 3 areas according what they compensate for. So there is some position compensation aids like wedgies, cushions, or belts. Some movement like intimate rider, hoist, lifting system. But you can use the things for the rehabilitation, like is a ball or slip roll. You will see them in the part of the sexual position. And for the stimulation, for the sensual stimulation and masturbation, you can use some vibrators, masturbators. You will see them. So the next one is the position tools. its wedges and pillow with the belt. These aids help to maintain the position of the lower limb and the woman's body. The belt helps with the position of the lower limb. Can be replaced by pillow or blanket, but it's necessary to know that it must make the harder. So you can use all blankets or pillows what you have at home for sleeping, but you must make it harder. And straps you can replace by some scarf or some belts what you normally use, but be careful of some injury. And a lot of this tool you can find on the sex shop, like bondage tools, how you can see in the next slide. These toys are from AliExpress, but it doesn't matter where they are from, but it's international, so I think that everyone can buy them. And it's normally the belts from the bondage, but you can use them for the sub on the body and the position of lower limb. And in the another slide you can see some motion compensation aids. This illustration are from the book Yes We Can Kama Sutra for Wheelchair Users that we wrote with my colleagues in Paraplacent. I will spoke about it in the end, but I would like to say you about this kind of the compensation aids. First, it's intimate rider or laugh chair, because we found in the laugh chair it was inspired by intimate rider. It's the swing, but with the armrest and everything more, because we have a problem with to bring the intimate rider into Czech Republic, so we find our new way. Second one is the body bouncer, and third one is the door swing. These aids are designed to carry the weight of the body and for to make a control a movement of the body of your partner. Okay, Nica, you can continue. This one is the motion compensation aids. How I say before, that you have, maybe you will have them for the physiotherapy in your practice. So, but you will see how we can use them for the sexual position in the next part. So, next one, please. These are very expensive things, but not too much usually in my country, because when you have a high injury, you can have some lift system at home for transfer to shower, for transfer to bed, and you can use them for the sexual activity too. So it's same like intimate rider, or that it's it's carry weight your body, so you can control the movement. You will see them on the slide with the position. And another slide, it's aids for the stimulation and masturbation. I think that it's very important to start getting to know how your own body as early as possible, to know what was changed, and you can explore your bodies by a lot of tools. You can use feeder, you can use the massage oil, or ice, candles. It's up to you, it's up to your option, but it's good to know that it's you always you start from the subtle sensation to the strongest one. And when you will use the different temperature, like ice or the candles, massage candles, you must be careful, because the sensitivity is changed to prevent some injury. The next one. I put into this presentation only something which I think that it's very special, but for the men, there is a lot of masturbators that you can use, but these aids are used for the penile vibrostimulation. It's not a medical issue like the Ferticare in the beginning it was, but we have the experience that these two kinds, it's not from normal sex shop. Like first one is from the Růžový slon, which is a sex shop in Czech Republic. The name is Fun Factory Manta, and it can stimulate the whole penis, and the level of the vibration that can vibrate on the frenulum of the penis, it's the similar like a Ferticare. So it can be used for the reproduction at home, and hot octopus, the second one can be used like this too. I think that it's very important to know that it's very important to touch these products, but when you imagine your occupational therapist mind into when you will research the sexual toys on website, you usually find a lot of sexual toys which has some different grip, like this fin vibrator. You don't need to grip them. You put the ring on your 2 fingers, and you can turn it on by the chin when you push the blue button, and you can use the hand grip as maybe your clients have them at home for exercising or for gripping something like handbags and so on. And now we will see how these tools or aids can be used for the sexual position. In this section, we will discuss about the sexual position and adaptations with the use of the aids. And there is a lot of possibilities what you can find on the websites and Instagrams and some diagrams, and sometimes some of them look like funny, like in the first picture when there is the sexual position on wheelchair, but it can be inspiring for you too. In the second diagram, you can see the body bouncer position, and in the third one is the using of intimate rider. But let's talk about Kama Sutra, which we wrote with my colleagues. We start the sex position for the man. I think that most common is cowgirl. When your pattern is up, you usually cannot be too much active, but you can support the activity by your hand. Or you can use a body marker. It's good when you have the rest of your backrest. It's good for you too, but it can have a lot of adaptation. For this one, the next one is missionary. It was founded by my colleagues. It's necessary to know that it can be available for the C6, C7, but this upright position can make your erection weaker, like another one what do you see in the next slide. And this how it's going on. You kneeling down on the bed and place a peanut ball between your calves and thighs for stability. So here you can see how you can use the peanut ball what you maybe have for the physical exercising. Your partner can put a wedge under her back. It's very necessary for to bring her hips closer to yours, and they help you into the kneeling position, and the movement is that you shift your weight back to the peanut ball, which will bounce you forward. And your partner can also push her foot on the wall if it's close to you. So it looks like difficult, but it's really function. And my experience that my clients my experience is that my clients is usually ask me for how they can be dominant in the sexual position. So this one option is adaptation of missionary position for high injured client. The next one, it's spooning. I think that it's more common too. The position requires a large and a bed or couch, and your partner is lies on her side facing away from you, but she can support the movement by the straps, but that you can see on this picture, and you can put the blanket or transfer slide under the pelvic for the help with the moving, or you can put some pillow in the behind you that can it can swim you back into your partner too. Okay, then another one. Here you can see okay, we start with the sit in wheelchair. It's most common place where usually sex experience start. Having sex in wheelchair, it's safe for all clients, but make sure if you don't extend the weight capacity of your wheelchair and pressure cushion, because I have experienced one of my clients that destroy wheelchair during sexual activity. So don't forget them if you will choose the wheelchair, to ask if it will be used for the sex too. And remember to secure your brakes or turn off your power wheelchair or locate the wheelchair close to wall. And here you can see on the picture the adaptation on doggy style for high injury man, using the lift system, which is normally using for the transfer. And it's good that this position gives you a lot of control and works well even for the men with high cervical insurance, because you can use the belt and grip your partner and support the movement of the penetration. The next one, in the car, the cowgirl can be done in front of seat of car, because it's offer you enough stability, but be careful, there is not too much space usually to injure something, and check if it's nothing is under your body. And in the shower, I think that it's a very good place for have a sex in the shower, because you can you don't need to take your clothes off, and you don't need to be scary that something happened with the urine or another systems. And you can also use the Hoyer if you have them. You will see them in the woman sexual position. And you can work with the temperature of the water for the sensation. Next, we continue with sex position for the woman. Cowgirl, I think that there is nothing too important to say. Maybe that it's good when your partner support the move of your hips to help you, or when he sit with the support body, and he can support your chest during the activity. But in missionary position, you can use a lot of tools or adaptation. You can use the pillows or wedges, how you can see on this picture. for the support your position of your body and bring your pelvic upper, and you can use the belt for the position of your legs, because there is a lot of problem, especially when you have the spasticity. It's good to use some straps for the check the leg position. Another one, there is a doggy style. You can use a lot of tools for this, for support this position. You can use wedges, you can use cushions, or you can use the belt, how you see in the beginning. I think that there is a lot of adaptations. It's usually safe position for you. And another one, there is, how I told you before, there is how you can use the lift on Hoyer for the for the women. I imagine this when the old women is in the Hoyer, because or lift. When I have one client, she asked me that she would like to be dominant in sexual activity, but she was stiff-eyed. So we try to find a way how she can be dominant, and this one is kind when she can make a move across the grip of hand to grip a body by raise the body of the partner. There is a lot of adaptation of using the hoiser, but I know that it's expensive, and it's not possible to have them for everyone. But you can imagine, you can use the door swing, how you see in the beginning. It's really cheaper, but it's still not the best choice. And now I would like to give speech back to Nica, because she would like to say you about some low-cost adaptation and her experience. So Nica, please.
Yeah, so we need to keep in mind, like as Iva said, a lot of these are very costly things to keep, and coming from a country where majority of our population is a low socioeconomic status, we need to look at making sure that our clients are exposed and feel as able, even without the expensive devices. So this is where our creative juices really need to start flowing as OTs. So this is the commode that's on our government tender. So it's an example of the only bathing aid that a majority of our clients will return home with. And it can be used in the same positions as when using a wheelchair. So the pictures that Iva showed you earlier, this can be used in a very similar fashion, just when washing, as she mentioned, when your clothes are already off. It does allow for a little bit more spontaneity, but also if you look at the little gap between right at the front of the commode, that is a nice spot for a female patient to be penetrated, just because there is that little gap opening. But keep in mind that the male would have to then, or the partner would have to be lower down and in almost a squat position in order to penetrate this way. And then we also need to consider the environments that our clients are going home to. So this is an idea of what informal housing can look like in some countries. And this is where a lot of our clients call home, specifically in our country. And here, the toilets are usually community shared pit drops. So you're really going to not have a high focus on, you know, the bathroom setting in terms of sexual functioning. This does limit the positions available, but we can just simply educate our clients on how they can engage in sex while either seated on the wheelchair or seated on a chair while being washed with a wash basin. So any opportunity can be used for sexual engagement. In this environment, we have to keep in mind that clients are likely to use more of a bed and wheelchair positions. So we need to make sure that these are being thoroughly explored in treatments, as well as the exploration of positions that require very little movement, as people usually share a single room and clients may want to remain discreet in these circumstances. Again, we need to highlight that in-depth assessment of each client and the context that they will be returning to is the most important factor in starting to treat sexual functioning. Thank you.
Thank you, Nica. The pictures and information that I told you about the sexual position, you can find in the book which we wrote with my colleagues from the Paraplat Center and from another two organizations. And you can, if you are interested and if you like the information what we told you, you can find it on our book, and you can support our work on the second part of this book. You can buy them by the credit card if you leave the email here, or you can buy a book by the bank transfer. So if you like them or if you would like to use them, it's in English. Yes, the book was translated from Czech language to English, so it's English.
I also think this is a really great resource for any department to have in their stock.
We did this book for the wheelchair users. It's wrote in the basic language to understand, and it's all what you need to know in the beginning. So it can be very practical, or it's very practical, and it can be very helpful for your clients, because there is some basic information which I think that everyone must to know. Nica, can you continue? Next one. And I would like to invitation you into Facebook group for the support our work in the sexual rehabilitation. We founded this group with my colleague Sandra Miles, and I would like to say hi to Sandra, which is attends today too. We open this group for everyone who can share with us experience, who can speak with us about everything for the sexual health life. It will be very wonderful for us to share with everyone, because everyone has different experience, and it's really doesn't matter if you are from the Canada, Pakistan, or India, or Australia. Your voice will be here. So if you can enjoy this group with us, we are really in the beginning, but we would like to make the group together and share together our experience. The next one, Nica. There is some resources and inspirative materials which I use in my practice, and you can use them too. Next one, please. And I would like to really thank you for everyone who support me, or people with of area of sexuality of the people after STI. It's very necessary to have some support and someone who show you experience. And I would like to say many thanks to all of these people, but special to all of my colleagues to Paraplat Center when I work, because they support me to grow up in this area and to bring you some another information. So many thanks, and I would like to thank to Nica for this presentation. Thank you so much, Nica.
Thank you, Eva. All right, so that is the end of our presentation, and we're just going to have a look at some questions.
Yes, so ladies, it seems a lot of the comments are to say congratulations and how fantastic you are, which is lovely.
Thank you.
Isn't that great?
Thank you so much, everyone.
Yeah, and certainly really nice comprehensive cover of equipment and positioning, and also I thought really great to have about the communication and how important that is, because that's the part I think you've got to start the conversation, don't you? So that's fabulous. There was a question about what you thought in terms of what the major OT role was. So I don't know if either of you have an opinion about that, or if you really cover the whole of the things that you spoke about in your presentation.
It doesn't matter which country you are from. In my country, the main role is have a consultation about the sexual life, sexual health, and sexual activity, and practice lesson. So I try to find a way in whole part which I have in my presentation. It's my work, but it cannot be the same in every country. But in my country, I have this opportunity. So I have the consultation and practical lesson when I work with the clients to support them. And my clients, it's the partner of my clients. It's two my clients. So I work with the pair of them. Do you know what I mean? If it's okay.
Yeah.
This
yes,
answer?
of course. So you're working with both the patient and the partner, which is exactly what you want, don't you? You want a practical solution to the problem. So some people
also, sorry, Nicola. I think it's also it's what you make it, because a lot of people, it's an area that's really easy to pass off and to say, this is not my role, or I can only help with positioning, but you need to get more information from the doctor. Or it's really easy to do that with sexual functioning because it makes people uncomfortable. But a lot of the cases, in my experience, if you don't do it and you don't address it as an OT in whatever capacity you can, no one else is likely to do it. So this is a gap where we are just perfectly positioned to fill and to educate, be positioned. There's so many aspects, and a doctor referral and psychology referral is adjoining to that, not instead of that.
Yes, quite right. I think we can facilitate as well as practical help and advice. So one question is if you have any particular assessment tools that you use as part of the when you're doing your consultation. Maybe you could answer that, Iva.
I'm not sure if I understand the question.
Yeah, so how do you assess? Do you just have a conversation with the person,
No.
or do you do a yes practical? Yeah,
I understand what you mean. No, I'm not working with the naked bodies. I'm not support the action, but I find a way how the action can be. So sometimes I'm work with the physiotherapist together to find a way how how they can go to kneeling for the missionary position too. Because sometimes you can find this position, it's too much for the client, and going into this position, it spends a lot of time. So it's not possible to have this because you spend more than 30 minutes to go to kneeling. Okay, this is not position right for you. So I'm supported. We have in Czech Republic, we have the sexual assistants. It's the woman or man which can has an intercourse, but me not. I'm only teaching. I'm working with body which is in clothes, not in real intercourse. But I think that I can do a lot of things, and I can tell them. And I usually talk about sexual assistance to my clients if they need some more support. I think that the best view when you looking on the sexual activity, like every activity which occupation therapists do, it's not different. It's still activity which is very important and necessary for everyone. So if you, and it was my start in this branch, I opened my occupational mind on these activities and start to work with everything. So this is my answer.
And I think it's the same, just to branch off of that. There's no standardized assessment or that I use for something like sexual functioning, in the same way that I don't use standardized assessment for dressing. and I don't use standardized assessment for feeding. It's, can the client participate to the level that they want to? So it's evaluation more from the interview and from actually, as Eva said, mobilizing the clients into those different positions and see what they can and can't achieve. But the communication, I find, is the one, the interview that I use the most, and then trial and error.
Yeah, excellent. So some people have mentioned a number of other assessments, and those will be, I guess, in the chat. But something
Amazing.
called
Thank you.
occupational performance inventory of sexuality and intimacy is mentioned, and also standardized quality of life sexual function questionnaire. So just some other ideas, I suppose, of more formalized things.
Thank you. Lovely.
So a couple of questions. One is around, can a quadriplegic woman get pregnant?
Yes, there is.
Absolutely.
Yes.
Yes.
Yes, perfect. All right. And another one, how do you provide privacy for a patient to do the penile rehabilitation, as you mentioned, or the vagina rehabilitation? Because we have a situation where people often share a room as an inpatient. So perhaps just how you address that.
I came from a setting that was very similar to that. And your brainstorming, I think every setting is so different that that's where that problem solving technique of an OT comes in handy, and looking at, can we cordon off a private room for a 30-minute use or a 1-hour use? So maybe not being done in their own bed, but possibly finding other areas in the hospital where it can be allocated time. And to be honest, now that I'm doing home-based therapy, it's far easier to facilitate because of that reason. They have their privacy. But I just think we have to get creative. We can't get complacent that because our clients in a public room, that they cannot
with people in the chronic phase, so they usually are maybe 1 year, least of 1 year after the injury. So I have different experience. They can try it at home, and but I think I have some information from Dr. George Sass. He is from Vancouver. He's 93-year-old doctor who explored sexual rehabilitation in the Vancouver, and he told me that when they start, they have a room in the hospital for these options, but I think that now they haven't. But they would like to have, and I would like to have a red room in my organization too. Hope that in the future it will be possible. For example, in Italy, in Roma, when I was in stage this year, they have the training flat when they can explore it in the spinal cord unit. So it's different in the whole world. It's different of the options what you have, and it's different from the part of the time after the injury. So that's my answer.
So someone's mentioned that they have there's an article about an occupational perspective of sexuality, which is great, and that's good to see the details of that in the chat. That sort of talks to the OT role, I suppose. And a question, Ivra, I guess primarily for you, but around whether you do cover the sort of alternative of, you know, sexual activity, not just with men and women, but other types of sexual activity, and whether that's in the book.
It's not primarily focused on, but we work on the second part of this book, which will be focused more on this group. But you can read something about it, but it's not special for this group. Yep,
excellent. Okay. And then a question maybe for those of you in South Africa about where mobility, where sexual activities aids can be purchased. So maybe I'll leave that with you, Nica.
Yeah, I've had trouble. Even me, I've had trouble. But one thing that I picked up from Iva that I think in South Africa and in other lower, I won't say lower resourced areas, because it's not about how resourced you are, but how available delivery options are to you, because there's some beautiful options available that don't get delivered to South Africa. And like what Iva did in Prague is we can look at these options and see if we can start making them, because there's so many beautiful ideas. The aids and adaptions in terms of for masturbating and things like that are available in most sex shops. It's just about going to find them. There are online resources like One Night Only that provide really discreet options available, and they get delivered to your door in a very discreet packaging. So those are options that can be explored. But in terms of things like your body bouncers and your love chairs, they're really difficult to get hold of. And as far as I know, I don't know of anyone who has bought one in. But yeah, I think we need to start getting creative and making. If they don't deliver here, then we need to start making them.
Yeah. And thank you very much for posting your comment. The gentleman who was speaking earlier just has mentioned that they have a halfway house where they can start on sexual rehabilitation in Bangladesh. So that's fabulous news to see leading the way in that. And also, Elma, you have mentioned about, the issue of not having access to specialized medical professionals, I think is what you mean, who are able to assist with sexual activity. So I guess that's where, from an OT point of view, it's even more important that we get involved in those conversations. And I think there's a comment about
I would like to thank for the discussion about the Pleasant model, which I see. I work on it. I work with the Pleasant model in my work. So I'm really happy that you discuss and have some question about it in the chat. Thank you. I'm not spoke about them today because we tried to put there are only some basics for the webinar, which is spent 1 hour, but we can spoke about it in the Facebook group, how I invited you before, and it will be my pleasure. Or you can see my and Nica's email in the beginning of the presentation. But thank you that you spoke about these models here.
Yeah. And someone's mentioned that they can we can do Zoom consultations all over the world, which is fantastic, which is exactly what we are doing at the moment. And a comment about making sure that we're inclusive in our language, and that's absolutely true.
I think there's a lot more research also that has to go into inclusivity. As Iva said, they are working on having a more inclusive book made, and it's an area that this is just the beginning of.
Yeah, I think that's right. We need to start somewhere, and it's a fantastic beginning, that's for sure. All right.
I see there's also a question asking what a client should do if they experience spasms during sex. Is it normal?
Yeah, and if I have some woman with high spasticity, it's good to use some pills before or check about it with the doctor, because it can be counterproductive. But it's good to know that orgasm make the spasticity low and has this treatment. The orgasm has this treatment effect. So you will have a sex with orgasm, your spasticity will going low. Not in the time when you will have an orgasm, but after.
Yeah. And also, I mean, any stimulation, especially one that is so stimulating, sex is a very stimulating activity. You do expect spasms to arise if it's something that you struggle with on a normal day-to-day basis. So I would say it's expected, but as Eva said, chat to doctor.
Yes, and thanks for picking that up, Fiona. I was going down the chat, but of course we did ask people to put things into the Q&A as well. So there's a request about medication specifically to prevent AD. If there's anything in particular you have to comment about that.
I wouldn't personally. I would direct the medication question to a doctor.
Yep.
In my country, it's tensiomine, and when you will look on the presentation back, you can see that there is the course from the Dr. Andrei Krasyukov. It's online. There is all information about autonomic dysreflexia, and you can attend them. It's free. So I know that there is a lot of country that they haven't this sexologies, then they haven't someone who specialize on, and I'm really it's really interesting for me that a lot of people don't know about the risk of autonomic dysreflexia, but you can go on this website and you can see there's some more information. And for example, if you would like to have some contacts on sexologists, but it's open to chat with you when you are not from the not from the same country, let's write me. I can answer you. I know that Dr. Mitchell Tepper, he is very fantastic sexologist from the American, and you can leave the question on his website and he can share information for you. But sometimes it's good to find someone who can help you in your country. Not sometimes, every time it's better to find someone who can help you in country. It can be some special neurologist, or it can be some another specialization, not sexology. Sometimes the practical doctor can help you too. Only you must open the question with the doctor and ask. And I know that sometimes it's difficult because there is the cultural and ethnic barrier, but without question, it's no answer.
Thank you so much, Iva. I think that's a perfect point for us to end on. I see it's 1 minute to the end. I know there's a lot of questions and we could actually talk about this for days. So thank you so much also for sharing your resource, your book, as well as the Facebook group. So I'd encourage anyone that's interested or has questions to join the group and we can engage there further. Like we mentioned in the beginning, this recording will be available on the ISCoS YouTube channel as soon as possible. I'll send it today for them to hopefully upload soon. And we'll also send out the link to everyone that RSVP'd on the link. We have your email address, so we'll send it out to you and you're welcome to share it with all of your colleagues. But with that, thank you so much for joining. And yeah, all the best going forward with sexual rehab with your clients. Cool. Thank you, Nica and Iva. You guys have been awesome.
Thank you. Thank you so
Thank
much.
Thank you,
Thanks,
guys.
everyone.
All right. Farewell.